a workforce development programme supporting the National Health Service. In our first 10 years, we founded just under 600 life science companies. Between them, they've benefited over 200 million patients and professionals that we can count, and we've now raised over £1.5 billion of funding, mostly from American venture capital, actually, to drive those forward. But then the other joy I had at NHS England is I was around at the time when we founded our National Innovation Accelerator. You'll hear about that. And I was involved in the Innovation, Health and Wealth Report, which set up the forerunner to the HINS, or the rebrand. The HINS are the new brand name for the academic health science networks. So what I'm going to do is I'm going to ask, so that's me and who I am. I'm going to ask each of our panel just to introduce themselves, because they each bring a very different experience. I've got a couple of questions I'm going to ask them around things, and then hopefully we're going to have a little bit of time for one or two questions from you. But then what I want you to do is, we've got 4 innovative companies here who are all deployed across the north that we've been supporting either through the Entrepreneur Programme or through our National Innovation Accelerator. All of them have been supported through our health innovation networks in one way or another, particularly in the north, that they're going to come and give 4-minute pitches, and then we're going to grill them a little bit and ask them what's good, what's not, and go like that, okay? And you're welcome to contribute to that as well. So Jack, why don't you start?
Great. Thanks everyone. I'm Jack Porter. I'm the co-director of the NHS, or National Innovation Accelerator. I've been in life sciences since I was 18, where I got my first internship. So I've done multiple different roles in pharma, diagnostics, personalized medicine, and then some health tech startups as well. One went really well, one went really badly, but it was good fun. And I've been running the NIA for the last 2 years.
And Jack, can I just ask you, what's the favourite thing you've got in your job that you do at the moment? What's?
I think part of my job is being a therapist for 50 founders and fellows, which is very good fun, but every day is different because everyone's got their own challenges.
Yeah, it's true, isn't it? It does feel like that, trying to get us. So you wouldn't think. And you know, there's a difference between the UK and the US. We are very good at testing and trialing here. We have some good networks and some good innovation infrastructure. In the US, it's mostly done in the tech companies. I learnt the other day, do you know what the most common advert in Silicon Valley is for now in the tech sector? It's something called FDE. Does anyone know what FDE is? I had never heard of it. It's called a forward deployed engineer. And suddenly the tech companies have discovered, instead of sending salespeople out, let's put engineers into the companies so they can understand the company's problems and help design that rapidly. And I'm going, oh, Health Innovation Networks, National Innovation Accelerator, Entrepreneur Programme, isn't that our version? But it's 10 to 15 years old of forward deployment of engineers supporting our frontline staff to help change the system in what we do. It's always bigger and better in America. Sorry.
Thanks, Tony. Hi, everybody. I'm Nicola Hutchinson. I'm Chief Officer of Health Innovation North East North Cumbria. I helped to found what was the Academic Health Science Network for the North East North Cumbria back in 2012. And I also act as an advisor to the North East North Cumbria Integrated Care Board with regards to innovation.
Brilliant. And what, in your role as a HIN CEO, what's the favourite bit of your job that you have? I might ask you the nastiest bit later, but the favourite bit.
I think the favourite bit is I'm from Newcastle and I'm gobby. I like to talk. I like to talk, and we get to meet lots and lots of different people from across a vibrant ecosystem. And I think the best thing is when you can join the dots and you can kind of be the glue and the cohesion, and you see things come to fruition. So I think that's probably the best.
And we're going to see you have quite a good track record of making innovation happen, actually, and we'll see that. We'll come up with some of the companies. Yes, next.
All right. My name is Vladimir Gubala. I go by Vlad because the name Vladimir, a certain person didn't make our name very good job, so let's just shorten it.
Is that Vlad the Impaler you're referring to?
Well, I'm from Slovakia, so not, he was in Romania, so I'm East European.
Okay.
Something like that. I'm a former academic. I used to be a lecturer at the School of Pharmacy in an unnamed university. So I was always close to healthcare. And in 2019, I co-founded a health tech company called PocDoc, Pocket Doctor, Point of Care Doctor, PocDoc, right? Yeah, easy. So we operate in a space of preventative healthcare. We effectively revolutionize the way health checks is delivered across the country. And we have a product that you can do a health check and stratify risk of cardiovascular disease in the comfort of your house, in the communities, in the middle of a field, or at football matches, mosques, churches, everywhere, and all in 10 minutes. Results stream directly to your NHS app, if you have NHS app, link with the GP Connect, GP records. So it's all streamed and all in a digital format way.
So I was going to ask you what your favourite thing is about what we do, but I want to ask you something different. Why do you do what you do? Because if business is about making money, you could probably make more money in another sector. So why have you left what you were doing to come and found this?
That's an interesting one. I think the answer is actually also relatively simple. When I was academic, and this is probably one of the things in academia, we always in academia, always, I won't say always, many of us will look at things and say, this is what interests me, this is what I want to do, and then we come up with some solution of something, and then we are frantically trying to find a problem where the solution can be applied. So at some point I had enough. I said, this is wrong. I mean, we should be really going after the problem first, do the due diligence, find out what the user requires, and then apply a solution to it. So that's where I switched from a very comfortable, I have to say, academic life is quite comfortable. It was really comfortable life for me, but in this private sector, it's a huge stress. But then the reward is, and that's where my favorite part comes, is when you actually see how the technology works in the world. So I don't spend time only in my little lab or in my office. I go out there, I spend time with nurses and doctors and pharmacists, and I talk to people how they use technology. And it's super rewarding to hear that I dream myself about how people should use my technology, what impact it should make. I can write thousands of words of how impactful this technology is, but nothing comes to even close when you meet a real person who tells you, I gave up smoking because I use your test and it showed me I have a high risk of cardiovascular disease. And now I'm slimmer, I run with my grandchildren, I play with them, and I have a much happier life. That is absolutely invaluable for me. So that's what I enjoy the most.
Isn't that really interesting? Because I had a group from the University of Washington came over recently to see me at NHS England, and they were looking at our health innovation ecosystem here in the UK, and they just said, do you know, we have nothing like this in America. He said, how do you get your workforce involved in innovation? Ours just are burnt out, go in, bill their hours, fill in their EPRs and go home. They can't get away quick enough. And all we have are tech companies coming to us with solutions they think work, but they don't understand the healthcare. So to hear your passion and your drive and your commitment, and I didn't ask you what your favourite thing was going to be, because I thought you might say it was going to be the therapy sessions you have with Jack, because you're on the National Innovation Accelerator.
Sure, we'll do it after.
We'll come on to that. So look, it's difficult. We have heard things are difficult at the moment, but I think everyone in this room is here because you want to make things better. You want to improve patient care. You want to improve patient experience. You want to improve the experience of the workforce. But actually, you want to do that scalably as well, not just, as we heard earlier, didn't we? I can't remember if it was Jim or Tom that said it about just one small area where it goes on, but the ward next to you or the general practice a few miles down the road. Maybe there's a question that came out earlier that brought that up, and it doesn't happen. So we just don't want to make that impact, but we want to scale it too. And we know it's really hard, and you know, evolution teaches us. So evolution just runs experiments, lots and lots of experiments, and then the mutation that work actually is selected and then goes and grows, doesn't it? So our panel between us, you've seen lots of experiments, you've done lots of things. Mark, what I want to ask, and I don't have the answers, I don't know what the lottery winning numbers are going to be this week. I know them from last week, not this week. But you can learn from the mistakes of others. You can learn from the experience. So are there any insights? And it's a safe space. And if you don't want anything put on social media, just say, that's fine. To say, are there any insights you've gained of where you've really seen something work and be taken up? And then on the other hand, you've seen examples of never do this again, never take this approach again. It was a disaster and it failed. Because sometimes sharing those insights, and where's the forum for talking about the absolute disasters that happened? You know, it doesn't happen, does it? Here. Jack, do you want to start? Insights you've gained from the NIA?
Insights. So on the NIA, we've got 53 fellows right now, taking about 100 companies to date over the last 10 years through the program. Some of them are now, well, all the big names within the UK health tech space have kind of touched the program at some point. And I guess if we're talking about insights in terms of what's worked well, what hasn't worked well, I'd pull out 2 words. So I think trust is the first one, which we can expand on. And then also a lack of complacency is, I think, very, very important when it comes to actually being an innovator, being a founder itself. I go to a lot of these events and I have conversations every day pretty much with an innovator who's got a solution which they're saying is not being adopted within the system. And I think there's a big difference between the NHS doesn't adopt innovation and the NHS doesn't adopt my innovation, which I think is a real distinct difference that we need to really kind of hit home on. I think if you go to enough conferences, you would think that nothing new has been picked up across the NHS for the last 10, 20 years, but actually in reality, that's not true at all. So NIA fellows at the moment, where they're averaging out about 30 deployments a month across the 50 that are currently on the program. So this stuff is definitely happening. I think there's the difficulty is in any other industry. So before I came into the NHS Innovation Accelerator, I was the commercial lead of one of the first fellows to go through the program actually. And we also sold to pharma. And in pharma, there are exactly the same problems that you have scaling within the NHS. Before you get a contract, you have to go through a 6-month-long IG process. Everyone you might sell into one department in pharma. They don't necessarily speak to the next department. Countries don't speak to other countries. It's exactly the same problems. And there isn't actually 15 health innovation networks, for example, helping us to do that. I can scale within that industry. So I think it's unique within the NHS here. So lack of complacency is one of the key points. And then I think trust is the other element to it as well. So I think all of these, everything is scaled based on relationships. Right? So it's a relationships game at the end of this. And trust is incredibly important to actually getting something to be able to scale across the system. And there are programs out there that can help build that trust, right? So NIA, Clinical Entrepreneurs Program, SBRI, the Health Innovation Networks, we all have our own due diligence and assessment processes that are tough to get onto, right? It's hard to get onto our program. We have 300 applications, we take on about 20 a year. So having those badges and across the different programs across NHS England and the wider kind of accelerated access collaborative, it's incredibly useful as well. And I think we should use that.
I think there's a great point. And just remind me, is the NIA still open for applications at the moment?
It is still open.
Good. I'm amazed you missed that. Yeah, 2 more weeks, still open. Have a look. Nicola.
Thank you. So yeah, I guess building on that. So I've spent the last 20 years of my career working in regional innovation in the North East and North Cumbria. I know I don't look old enough, but I guess during that time I've worked on thousands of innovations, and with that we built our innovation pathway, which became a regional blueprint. The Health Innovation Network isn't an expert at all in kind of all aspects of that innovation life cycle, but it's going back to the point you were making, Jack, about working in collaboration with partners who are the experts and working together, because we are stronger together and playing to our strengths. And I guess as part of that as well, the other thing we have to consider is about failing fast. You know, we get a lot of, not so much now, but in the early days of the Academic Health Science Network, we did get a lot of Mark 6th generation walking sticks, and I'm not even joking. People were spending their life savings on walking sticks, and the NHS already has a very perfect, adequate walking stick. So I think it's working together, but also ensuring that we fail fast and we learn from one another. But collaboration and trust, I would agree, is absolutely.
And it's a hard thing to hear, failing fast, particularly if you're a company and an innovator and you put everything in and you're getting that feedback. But I think what you're hearing, the honesty and trust, and I think honesty then brings trust, is, and Vlad, you've been on the NIA, you've been supported by our health innovation networks. You will have had some very honest feedback, I have no doubt, in some of this. What, from your perspective as an innovative company, what are the insights that you've got that would say, this has helped us and this hasn't worked, this is what I valued, this has been of no use whatsoever? And it may be failing fast in an area and knowing in that part of the country, I'm just not going to get this over the line because they've already got something that's not too dissimilar, but not quite the same. You know, what is it?
I mean, every company, every health tech company, whatever solution we propose, the one thing we need to sell it, right? And then to sell it, you need to validate that the solution actually works. We were fortunate, lucky, whatever you call it. We partnered with the right partner at the time, and we were partnering, actually, Nicola knows, with High Nenk, so Northeast North Cumbria. It was part of a pilot project at the time when we were deploying 10,000 of our tests to screen just a relatively small cohort of people out of 500,000 eligible people in the Nenk region who are due to have health checks, and 50% of them never had the health check, although they were actually eligible. So we only started with this 10,000 small cohort. By now, we surpassed this number, obviously, we're way beyond that number, but this proved to be extremely valuable for us as a company. And there's the partnership and trust and the fact that we, whether it was serendipity or whatever, I don't know, but we picked a partner, we kind of ran into each other, that there was the trust and the fact that the partner was able to embrace technology. Because we also, obviously, in the meantime, there's 40-something ICBs across the country. Not every ICB is that open. Not every ICB will be welcoming technologies. But we were fortunate at the time that it just happened very well with the High Nenk. And that's just simply how it all started. So we're expanding.
Vlad, in a safe space, what's been your biggest mistake?
Mistake was, I wouldn't say the biggest mistake, there were always hiccups, and there always are and will be hiccups. One of the hiccups was that at a certain stage, we considered that we would outsource the production and the manufacture of our product somewhere else. You can guess where. I mean, there's one place in the world where they manufacture everything. But we very quickly backtracked from that, and we now fully manufacture everything in-house. And it was a big learning curve for us, lots of time wasted. So lots of resources wasted too, to realize that actually to have a full control over manufacture process and the quality of the product, we must manufacture here. And we actually source almost the entire inventory, entire stocks of what goes into the product from local sources or from at least European sources. So that was a big learning curve.
It's a great sales pitch to this audience.
That's
a great sales pitch. Right, I want to move us on. I've got one more quick question. Is Lamanos, my colleague from there he is over there, just stand up and wave, there he is. Right, you'll see why he's important in a minute. You might want to go and talk to him in the break over there. So one of the things that I have been trying to do, and I have failed as a leader at NHS England for 12 years, I have tried to persuade my chief executives, my other directors, government ministers, that now after 23 years, it is time that we as an organisation updated our intellectual property policy for the nation. I think 23 years, smartphones weren't around. We just about decoded the genome. AI, I'm not sure it existed in that form. Certainly not quantum. And when new government came in, and I thought, I'm going to have another go. And I went to see Baroness Merron, and she got on board. And now Minister Ahmad, our newly appointed minister responsible for innovation at the Department of Health, is our backer and supporter, and we are anticipating later this month, maybe I might drift a bit, we haven't got an exact date yet, but later this month, for the first time in 23 years, we will publish updated intellectual property guidelines for the NHS. which is, I'm so pleased, because that will really help innovation across the system and what we're doing. And if you've got any questions you want to ask, Lamanos is over there. You can go and see him in the break. That's why he's here. It's from our commercial team at NHS England. We've worked across the Department of Health, the NIHR, with our health innovation networks as well, and we'll come on and talk about that. But what I wanted to ask each of you briefly, because in commercial negotiations, you know, we've heard about, we want to get economic growth, we want a national growth service, not just a national health service. How do we get companies to manufacture, to build their products here, to test and trial them here? How do we get that benefit from that innovation here in our economy? Have you got any examples, either good or bad, related to intellectual property that you want to share? And hopefully Lamanos is going to have all your answers about IP in the break. If you haven't heard Lamanos, it's over there. He's the one to go and see, all right? Right, Jack.
Okay, so I'll start, I think, with an example of how big the prize can be. So has anyone here heard of Nerve Center software, right? So Nerve Center was one of the first companies to go through the NIA in 2015. So they joined us when they were, I think, 8 or 9 people, 1-2 years into their journey. And have co-created their product with the NHS. Now, I don't believe there is a commercial deal in place with Nerve Center, but now they are 300 plus people. They won more EPR contracts than any other provider, so the big US providers in the UK last year. And all it's going to take is one international contract for them to be able to pay back all of the support they've had from the system over the last 10 years. So winning just one contract. So I think that's an example of, you know, if we get it right, that's what we can bring back. In terms of where it hasn't worked, and again, we've seen examples of this on the program, I would ask everyone to ask themselves the question, like, would you rather have 50% of, would you rather have 5% of 10 million or 50% of nothing, right? Which is, I think we've seen quite a few examples where in IP, but also within kind of commercial partnerships and joint ventures, where a organisation is suffocated by too much control being taken by the NHS partner within this. And actually, we need to take a bit of a step back from those, let people get on with what they need to get on with, which is running and scaling a tech company, and be happy with letting them get on with it as well.
So your view is very aligned with Lord Valence, our science minister, who shared his opinion with us on what he thinks. He supported ARIA, our Advanced Research and Innovation Agency, where he really wants to kind of seed the cloud, as he puts it. You know, DARPA seeded the internet, didn't they? And the American economy has massively scaled, but it doesn't own the internet, does it? So there is that approach of how do you get that. Nicola?
Thank you. So I guess I've really welcomed the review of the intellectual property policy. I know you and I have, it's like Groundhog Day, Tony, we've talked about this for about 15 years. Intellectual property feels like a mastermind subject for me, I love it. So in the North East and North Cumbria, we are a little bit different in terms of the Health Innovation Network, because as part of our inception, we actually consume the NHS Intellectual Property Hub, which is where I came from. So I guess as a Health Innovation Network, we have that holistic approach across all of our providers, our ICB. We've drafted all of the IP policies, which I guess has helped us in terms of what have we done well. We know what the trust are producing. We know how to kind of engage with industry, and I guess that then has led to some of the work, and Sam alluded it to this morning, around kind of us executing deals with the likes of Boehringer. So I guess there's more of that to come. I think the guidance, we've worked closely with DHSE on the guidance, so I think it gives more practical examples and support for those regions that maybe haven't had the beauty of having an intellectual property hub working with them. So I think it really gives, it gives great guidance and great hope for the future. So things that haven't worked so well, I guess, is when people don't consider intellectual property being important and it's an afterthought. And then, we've seen some great examples of fantastic innovation that would really, really change patient lives. But unfortunately, the intellectual property is being destroyed and it's not being considered from the outset. And therefore, as a consequence, those innovators haven't been able to secure investments. And it's been really, really tragic. And as a consequence, we end up with one-off prototypes that kind of the press will get a hold of things like, the medical physics department in Newcastle knocked it up in the shed. It's not commercially available. And it's a result of that kind of it was an afterthought. And unfortunately, that really inhibits innovation.
So you're right, and I hope when you see them, when they come out, we've had to take an approach that's flexible to allow the kind of very libertarian view that Jack has kind of taken, to going to the other end, to saying there's a responsibility on us as a receiver of public money to make sure we're protecting things and supporting them. Vlad, what's your experience of working with the NHS and contract negotiations and IP, and how have you found that working with them? Have you done deals? Have you worked with them? What's happened? What's your experience?
Our experience with IP as a company is I'm a little bit torn always with this IP issue, because on the one end, I understand the importance of the IP and the fact that NHS also requires it and whatever, but at the same time, my view, the strategic view, is that I will only protect intellectual property if I can police it. Sometimes, again, coming from academia, we try to protect everything, every idea, every sneeze that we had in the office, we try to put on a paper and pay £15,000 just to write it up as a patent application. But the reality is that if I cannot police it, I would rather keep it as a know-how, because by filing a patent application, you effectively are putting it in the public domain, all your secrets and everything. But if you cannot police it, you're just telling people, here's the recipe of stuff. You can do it anytime you like. So it has to be a bit of a sensible approach. I do like the fact that the guidelines are being reviewed, because it's absolutely due. But at the same time, there needs to be a more sensible approach of what is it that we're trying to protect. And some things are more worth to keep as a secret. Coca-Cola is a good example, isn't it? The most successful drink in the world, still keeping the recipe secret in the vault in Atlanta.
Yeah, no, and I hear lots of companies talk about the importance of that, particularly with some AI things, which are much more difficult to patent. That know-how thing is really important. Now, I am running a little behind time, so I'm not going to open up to questions just yet, but I would like you three to stay and listen to the pitches that are about to come, and you can ask a question. It can be, don't hold back. If you've got something bold you want to say that you don't think's been answered, and if you've got something complimentary, you can say that too. First up, we've got 4 minutes, so I'm going to time you. I'm going to sit in the front row. I think it's Laura. Four minutes, Laura.
I know, the clock is ticking. Go as fast as I can.
Have you got a mic? Or?
I've not got a mic. Can I have one of the legacy ones? There we go. Thank you. Perfect accessory for my outfit as well. Amazing. Where am I looking? I'm looking here. Perfect. Good afternoon. Let me start by acknowledging the very real challenges that we're facing when it comes to children and young people's mental health. We're all acutely aware of the workforce crisis that we face, rising demand for SEN support, huge demands in emotionally based school avoidance increasing, CAMS referrals at record highs, and long waiting lists stretching beyond what families can tolerate. And at the same time, the 10-year plan is asking us all to work differently and to take on a new approach, shifting to prevention, to community, and to digitally based services. And that's really where we come in. My name is Laura, and I'm the founder and CEO of My Happy Mind. I'm also a trustee at the Mental Health Foundation and a proud NIA fellow, and I can confirm also one of Jack's therapy clients. My Happy Mind is a whole school mental health programme that teaches every child science-backed habits that support good mental health. Delivered through a digital platform, it's easy to scale, consistent in quality, and fully embedded into the daily life of schools. It's delivered by teachers, enabling a palpable culture shifts in schools. In practice, we enable schools to provide effective early help and preventative services. We change the reflex in schools from being one of referring children out to supporting children within. We're commissioned in 40 places across the system and impacting 1 million people now, working in over 2,000 schools, and we're very proud to be commissioned across Greater Manchester, Cheshire and Merseyside, North Yorkshire and West Yorkshire. We've shown that we can deliver a 46x ROI in year. And these returns aren't just theoretical. They're built from tangible outcomes. Fewer children being referred to CAMS, fewer children being referred to mental health support teams, fewer demands on SENCOs from within schools, and improved attendance of those children for whom the school system often means they get excluded. In short, we create a system whereby less demand flows into already massively overstretched services within the NHS. We're effectively an educational solution that delivers healthcare outcomes. We work hand in hand with systems, and in some areas we form part of the mental health support team offer, enabling them to scale faster, more cheaply, and with better impact. We also support the neighbourhood approach to mental health, where schools don't sit outside of the pathway, but sit firmly within it. They become the first line of prevention and early help, easing the load on specialist services, while ensuring that children get the right support at the right time and in the right place. We all know about the 3 shifts. I don't need to repeat them today, but My Happy Mind is an absolute example of how this can work in practice. It's about moving care upstream, delivering care closer to home in schools, and truly focusing on prevention. So when you think about the system challenges that we all know we're facing, demand, access and workforce, remember the name My Happy Mind. We're here to support you. We're proven, cost-effective, evidence-backed, and we can take massive pressure off the system and deliver a significant ROI in year. But most importantly, we're supporting to help children be mentally healthy within school, within their communities. Thank you.
Brilliant. And just under time, that's what I like. What you do is remarkable.
Thank you.
It is the most important thing, isn't it? You know, children's mental health and well-being, getting it right. Any questions you'd like to have for Laura?
I've got one around mental health support teams.
Go ahead.
So I know we're facing massive shortages in terms of the actual mental health support teams and the amount of volume of work that's coming through. So could you expand on where this fits into that?
Yeah, sure. So mental health support teams, for those of you that don't know what they are, exist to support really that stage before children get to the stage where they're being referred into specialist services. And they have 3 core functions, one of which is to deliver something called the whole school approach, which is essentially to help schools become mentally healthy, which is basically what we do. So where we're partnering really effectively with systems is that we're delivering that component of the mental health support team. But because we deliver via teachers rather than relying on a healthcare workforce, we can just do it much quicker, much faster, and importantly, much cheaper. In the 10-year plan, there's a goal that by 29-30, every single school in the country will have a mental health support team, but there's no extra money. And so every time I talk to our commissioners about that, they kind of laugh and say, how on earth are we going to deliver that? And that's where we can come in and support.
Good, thank you, Jack. Any more? I've got one quickly. So I said something very nice, and now I'm going to give you some other feedback.
Yeah.
What do you want? What's your ask of this audience? Have you come here just to tell them how it's wonderful what you presented, but make them do some work for you? What do you want from them?
So my ask is that any of you who have a role in or a contact in children and young people's mental health, where you see your system is, I'm seeing some nodding heads, which is always good. Your system is right for doing something a bit differently, but something that's very proven. Absolutely, come grab me in the break, and I can tell you more.
And your details are on the slide.
They absolutely are.
Okay.
Business cards as well.
Great. What a great thing. What a great Laura. Thank you so very much again for seeing. Taz, you're next, sir. 4 minutes.
I need to just plug in. Okay. Hello, good afternoon everyone. My name's Taz Aldawoud. I'm a very proud Leeds Medical School graduate, West Yorkshire GP, but I'm also the CEO and founder of Abode. Our vision's simple: to help the NHS save lives by getting the right person to the right place at the right time, delivering care closer to home. Across urgent and community care, believe it or not, staff are still using spreadsheets, WhatsApp, siloed systems to deliver care. The result is delays for patients, wasted staff time, and unnecessary hospital admissions. This is the productivity challenge we're here to solve: accelerating access, improving coordination, and empowering care at home. Abode is a workforce coordination platform. Think of it like an air traffic controller for urgent community care. One shared workflow powered by real-time data. Frontline staff use a secure mobile app, while coordinators manage the service through a secure web portal. It brings together live information on staff skills, availability, location, and service demand, so coordinators can see the whole picture and use resources effectively. For leaders, it provides real-time visibility across services, enabling proactive management and smoother cross-boundary working. Through real-time, high-quality, trusted data, operational teams can see pressure points early and respond instantly. For staff, it means fairer allocation, lone worker protection, and less duplication, building safety and workforce confidence. And at a system level, it supports pathways like urgent community response, virtual wards, discharge to assess, reducing hospital pressure by delivering more care at home. Abode doesn't replace what services do well, it helps them do it more efficiently, more safely, and at greater scale. In North Central London, Abode is embedded across all the trusts as an ICS exemplar, enabling system-wide coordination at scale. This shows what's possible when coordination works without friction. The same approach can be replicated in all trusts and ICBs nationally. The impact is proven. In Camden, productivity more than doubled. The service capacity rose by more than 70%. Agency spend was slashed to zero, all while staff confidence signals strong satisfaction. This was achieved without hiring additional staff. It simply unlocked capacity already within the system. NHS England now cites Abode as national best practice, proof that it's part of the playbook for community care. Independent modelling by UCL partners shows the scale of impact of Abode was adopted nationally across all UCR providers. Over 575,000 additional urgent care contacts in the community. Almost 945,000 released non-elected bed days, and more than £493 million saved annually, with an in-year ROI of £16 for every £1 spent on Abode. This is independently validated evidence that digital workforce coordination can unlock NHS capacity at scale without additional workforce. Abode offers a system-wide command centre, one shared view of capacity, faster, safer triage, more productivity with the same workforce. Live data-driven insights mean decisions are proactive, not reactive, giving back time for staff to care. And finally, the NHS needs to do more with the workforce we already have. Abode is proven, it's scalable, and it can be a national solution that unlocks capacity and delivers care closer to home. We'd love to have the chance to explore how this could support in your systems. Thank you very much.
Look at that. Bang on. And you've got some infectious disease today, so it wouldn't shake my hand, so I'm not going to get close. So my question, I'm going to get to go for, where are you working in the north?
Well, we were working in West Yorkshire.
Right.
We actually heavily pivoted because we launched in GP out of hours in West Yorkshire, then in Manchester, then North West Coast. And then during COVID, our whole use case died overnight. So we had to completely pivot.
Where are you from, did you tell me?
From, well, been in West Yorkshire for 20 years. Yeah.
Come on, homegrown boy. Seen the results. Seen the results. Yes. Any comments, any questions? Yes, Nicola.
I was just going to say the same. Where are you working in the north? But you asked, yeah. So.
I mean, I'll be honest with you, it's rare, but I've had more traction in North London than in North. But we started in West Yorkshire, grew across to the other side of the Pennines, but now our customer actually focuses.
You're an export south of the wall, aren't you? That a great northern export, but you need it here. Nicola, what do you think? It sounds great, doesn't it? Can he have a second? Can he get a second date with you to find out what it's like in your area? Can you? And Richard, can he come as well? And Phil?
Yeah. Richard supported me from the very start, to be fair.
Any other thoughts, questions? Yeah, Vlad.
That's a question. So
great presentation. You described the coverage in London and other areas. Are you fighting with the ICB system similarly as PocDoc is fighting, or are you already at a stage where you can roll nationally somewhere across the
at this stage, we're doing it trust by trust, and where the ICBs have the maturity to work with us. A lot are in a lot of state of flux with operational and structural changes. But what we found, especially in London, I know, supported by NIA, was once one ICB did it, and the regional team brought everyone together. We don't have a sales and marketing team. We're growing by word of mouth. And actually, when they start talking to each other, I think the carrot has now beginning to turn into a stick, because they've seen the evidence firsthand, and that's how we've grown, really. And now we're outside of London.
We're experiencing the same thing, pretty much.
So I think there's some help on the way, which is the Innovation Compass and Passport. I know you won't be affected by the rules-based pathway unless you're a medical device, a registered one, but we are doing some things that work. So we have listened to her. Did you want to say something quickly, Jack?
Yeah, just really quickly. I think if anyone in the room wants to talk about backfilling staff, which can champion these innovations, I'd be very up for that conversation, because with Taz and Doc Abode, the spread across London has been driven by one individual at North Central London ICB, who's doing this out of goodness of their heart, really. So it'd be very interesting.
Great northern innovation, working in the south but not in the north. Go and have a seat. Well done. Umar, you're next, sir. 4 minutes.
Can you all hear me okay? Oh, that works. Okay, my name is Umar. I'm a NHS doctor. I'm on the clinical entrepreneurial program. We're supported by the NIA, supported by SPRI, supported by NIHR, supported by Innovate UK, so thank you very much. We are a health tech company that is working in primary care. And so we're covering at the moment 4.4 million patients in 38 ICSs, over 500 practices now. As a CE marked medical device, we integrate with eMST System 1. And what we do is help turn this graph like this and move care towards the left, improving care in primary care, looking after chronic diseases. So, okay, I won't try and sell you this. I think we've talked enough about that. But the reality is that although 90% of costs are chronic diseases, although 50% of funding for primary care is towards proactive care, only 25% of capacity is being used for proactive care, because we're spending all of our time looking after reactive care. And the reality is that what we're asking GPs to do is to deal with a bunch of KPIs, national, local, regional, CQC, IAF, etc., whilst they're trying to deal with this demand. So we're not really helping them do enough to actually deliver what we're asking of them. And so what that means is that you've got 10% of the population overdue a test we know they need, and we keep bringing them in, doing half the test they need, and then sending them back out again, and then trying to get them to come back in again, which is not a good experience. And this is a product software issue, but it's also a coordination issue, and Abtrace solves both. So what we do, and we've integrated with these legacy electronic health records, and I won't bore you with that journey, pulled out the data, figured out what every single patient needs for every single chronic disease for millions of patients on a daily basis. And what we're able to give to the fingertips of every single clinician, whether they be a doctor or a nurse or an HCA, is I know what this patient needs and I can make it happen. In fact, Abtrace will make it happen. It will find the people, tell them they need something, and give them an appointment of their choice without anybody doing anything at all. So what we do for the patient is we also tell them why you need what you need and when you need it. So the patient has control. They can submit their own blood pressure from home. They can go to the pharmacy. They can choose when things are convenient. And we change the patient's experience of how they're getting care and get them more involved. And finally, we now work with payers, ICBs. So we also give ICBs real-time insight as to who is getting care that you're paying for. Rather than waiting for 2 years to get the impact of a new KPI, you get that impact that day. And you get to see that across millions of patients. So that's what we've built, and we work across this entire system, the entire stack in 38 ICSs. So it's good for the practices. They save money, they save time, they're able to do more, they're able to increase their income. The ICSs get total visibility about what their different PCNs, practices, down to an individual staff member, an individual patient, and you get these feedback loops. So these are not just dashboards telling you something is wrong. When you notice that some population is not being addressed, there is a mechanism for increasing capacity and actually doing something. So this is a functioning intelligent health system that is working across the country. Tony's going to get upset with me with the slide because it's not readable, but what the slide is trying to say is there's 39,000 heart attacks that we can stop over 10 years for an ICS. So it's not just about efficiency, it's about changing the outcomes of these patients long term. CKD prevalence, finding those people and actually treating them. We've already, this slide is out of date because we sign up 50 practices every week. We've signed up 30 practices this week. It's Wednesday today, I think. So we're terrible at reporting, but we're doing 50 deployments ourselves just every month at the moment. And so we're identifying new patients, getting them on the right drugs, monitoring them, up-titrating them, all automatically. And it obviously has an impact on inequality. So this is smear data. The practices in green are the ones using us. Their prevalence is much better.
You better wrap it up. You're done. Well done. Well done. Good. I liken this to the Formula One teams, you know, that have all that sensor data coming off the cars as they do laps, like our patients are like Formula One cars doing the laps and we're just monitoring them. That's what Abtrace is, really. Isn't it amazing that you can do that at scale for the population? I think what you do is wonderful, but you pitch too long. And what was your ask?
What's our ask?
You can see why he was worried about my feedback.
Yeah.
So I don't know, it's just on. But do you know that honesty is actually compassionate? I genuinely care about the companies, and I think everyone here does, because we're not going to put our arm around you and tell you it's wonderful. We're just going to tell you how it is. So what do you want from this lot?
Being very honest, we're doing very well, and I think we are useful for ICSs and practices. Actually, what's interesting is that although we've had so much support from the NHS, our investors, we've been very lucky, secured lots of VC investment. Our investors are in Berlin, in Portugal, and in the US. So that's interesting to me, and I think that maybe we could do more. We'll be fine, we'll raise lots of money, but it would be nice to be able to do that from the UK, because we're very much one and from the NHS.
It would be a great success story here, wouldn't it? That's good. Any questions from anyone? Yes, Vlad.
I have a question. You managed to go through the 4 minutes without mentioning the words artificial intelligence and machine learning. Does it mean that there is no artificial intelligence and machine learning in your technology? And the second question, could it or should it be?
There is in other products that we're building, but not what I've shown you, because what we want to do is to be totally deterministic. So we don't want the thing to hallucinate and make incorrect assumptions. This is a certified medical device that we spent years building. You can trace every single recommendation we make down to the specific NHS guideline that we're making. So we intentionally don't put AI in that decision-making engine. We do for other things, which I haven't presented today.
All right, thank you.
Nicola, yeah?
Really, really good. It was more of a comment rather than a question. So we support something called CDRC, Clinical Digital Resources Collaboration in the North East. It's a locally born innovation. There is significant synergies. It sits across EMIS and System 1. There could be sort of lots of merit of us talking and lessons learned, that kind of thing. CDRC has been integrated into our ICB, but I'm sure there's potential to learn from one another.
Look at that. I'd say to them, what you want from a pitch is you want a second date, and you've just got one. All right, go and have a seat. Well done. Right, last start, Julian. You get 4 minutes, sir.
That's just... Good afternoon. I'm Dr. Julian Nesbitt, a GP and founder of Dr. Julian. As we all know, across the NHS, mental health services are under huge pressure. Patients face long waits, services are fragmented, and clinicians are overwhelmed with admin. Too often, people feel lost, stuck between services, and unable to get timely support. We need solutions that give people early access, empower patients, and support overstretched NHS teams. That's why I founded Dr. Julian. We actually started out as a therapy provider on a mission to improve access to care and empower patients. But over the last 9 years, we've built a comprehensive, regulated digital platform to support our own services. But this platform has now evolved into a modular infrastructure that supports clinicians, engages patients through personalized dashboards, and captures outcome data in real time. Alongside our technology, we provide direct clinical services through our network of over 400 qualified clinicians, covering the full mental health spectrum, from talking therapies and counselling, to psychology, to ADHD services, maternity services, eating disorder services, and child services. This means that we can give patients immediate access to the help they need, whilst also supporting NHS staff and wellbeing services. We're not just a concept. We're already live nationally. We've delivered over 220,000 sessions ourselves and more than 1 million sessions through our tech licensing model. For the likes of Lincolnshire, Oxleys, Milton Keynes, Gloucestershire, and lots of other NHS talking therapy services, we support them in direct therapy delivery, improving outcomes for them and reducing their waiting lists, as well as saving them money. But from our technology perspective, in Scotland, our platform is powering the national digital front door for mental health with the Sam H charity up there, including digital triage, population level and localized resource libraries, personalized self-help tools, appointment booking, and telemedicine functionality. And locally in Cumbria, our platform is being deployed as a digital social prescribing tool, supporting prevention and helping people back to work with localized and personalized self-help tools through our resource library builder and resource libraries. It's also about to be deployed to support NHS staff across the region, giving them immediate access to therapy with no waiting lists with our clinicians. And for national organisations like NHS Practitioner Health and Vita Health Group, our platform is actually the backbone infrastructure that runs their entire service. The key is flexibility. Systems can use as much or as little of the platform as they need, whether that be a population-level resource library for well-being and social prescribing that can actually be localised by region and collect outcome data, an ADHD pre-screen to reduce inappropriate referrals, return-to-work tools, or direct therapy access to our clinical services with no waiting list. Or it could even be the full infrastructure with our case management, bookings, assessments, telemedicine, therapy tools, outcomes tracking, and a lot more. So we've gone from being a therapy provider to building our own technology to now being the infrastructure for mental health delivery at scale. Our platform has been shown to halve did not attend rates, hugely improve recovery rates, double engagement rates, and we're the highest rated mental health service on platforms like Trustpilot from patient feedback. We've also delivered significant cost savings to the NHS. We're proven, regulated, and already delivering nationally, and we're ready to continue scaling across the north of England, so we'd love to explore how we can plug into your priorities to make mental health care more accessible, more efficient, and more effective for the populations you serve.
Amazing. Well done. Don't sit down yet. Don't sit down yet.
2 seconds over.
And is that a first you've done in Cumbria in supporting the workforce in the NHS?
We do it in Lincolnshire, and yeah, we do quite a few different NHS workforce support.
They're
on massive
any
waiting
questions
lists.
from anyone on the panel? Just tell them about the size of what's happening in Cumbria, this contract you've just got.
Yes, so yeah, we're going to be delivering, supporting NHS staff across the region, and then I think what's interesting with the technology, it's evolved over a long time.
How many staff are you going to be supporting?
There's hopefully the whole region, so and then the patient population, so you can sort of use the tech in different ways, so the resource library and so yeah. It's depending on the budget, it can be as many staff as anyone wants.
Okay, and what do you want from this? Taz is going to have a question. What do you want from this lot?
Well, it's just we're there, and yeah, we'd love to. There's lots that we can do. We're doing it in lots of different ways across the region, but so yeah, come and talk to me if any of what I've said is interesting.
220,000 appointments now through that platform. How amazing is that? Laura, how many were you? How many? A million.
Yeah. So ours is 1 million on the tech side.
Competition game. One question, Taz.
Yeah, it's actually a comment. A very close friend of mine who's a doctor was telling me about this platform, and it was a lifeline. And I only recently found out it was your product, actually, Dr. Julian. And I haven't told you that yet. So
Nice.
Yeah, it's actually, I think it's saving lives for healthcare professionals.
Thank you. That's very
I agree. And when you hear, go on, you give me a round of applause. When you hear those stories, we've heard it in maternity from Gemma Paul, who I think was here last year or the year before, one of our fellows, who said when a woman goes to see her GP and has a mental health issue, it's going to be 6 months before they can see someone. But with your platform, you can see them straight away.
And it's also about underrepresented groups, because if you've got people that speak different languages and different cultures, and you've got a much wider network, you can actually get people that help, because a lot of them weren't getting the help because they didn't want to talk to someone that wasn't of their own language or culture. So we were able to bring them together.
Okay, well done. Go on.
Thank you.
Look, so thank you very much to all our pitchers. And I hope you've seen that theme of how it's digital. It's going out into the community and getting that shift. And it's been about prevention and maximising what we do, as well as productivity and economic growth. One last thing. Any last one thought you would just like to leave, or one ask any of you have for our audience here? You don't have to have today. Yeah.
I've got one. It's been consistently mentioned throughout today that as a system, we're not very good at picking out what's working across the system. That's what we're here for. That's what the NIA is for. And we're working really closely with 15 health innovation networks to make that happen. So speak to us, check out our website. You can see 53 things that are working across the system right now. And
Jack offers free therapy sessions for companies, was the other thing. Nicola, anything you want to add?
I think Jack said it.
We've covered it. Vlad?
This is a good one. As my company reps, we're always looking for partnerships. Okay, so please approach me if you think you want to try to actually do health checks, deliver health checks in a way that you've never done before. We are there for that.
Brilliant. Thank you very much. So thank you to our panel. And I get one last ask because I'm the last one to speak. The Clinical Entrepreneur Programme is opening for applications in November. I think 3rd or 4th of November, it's open for the whole month. If you work in the National Health Service, and even if you're at the very start of your journey, you don't have to be so mature to go on the NO or anything, because for us it's about developing the individual and the human being, the leader of the future, to go on and work with our NIA, to work with our HINs to help transform them. Have a look at it, nhscep.com.